All right, y'all want to take a quick like 5-minute break before we do cardio? Okay, let's do that. Let's jump into cardio. So I think it's safe to say that you guys don't really need us to tell you where the heart is or what it does, right? Like we all know that it's in the chest. It beats day in, day out. It keeps us alive. All of that kind of stuff. Now, anatomy wise for it, size wise, it is often described as a triangular organ shaped that is roughly about the size of a closed fist. The blunt point at the bottom, which is the lower edge of the heart, also known as the apex, that does lie on the diaphragm and it does pull a little bit towards the left. The heart is positioned in the thoracic cavity between the sternum and the thoracic vertebrae. Because of this placement, it can be compressed, squeezed by application of pressure to the lower portion of the body of the sternum using the heel of the hand. Our rhythmic compression of the heart in this way can maintain blood flow in cases of cardiac arrest. And if it is combined with artificial respiration, then the resulting procedure is called our cardiopulmonary resuscitation or CPR. If you cut open a heart, you can see that many of its main internal features, so it's going to be hollow and not solid. A partition that's divided into right and left sides, and then it is going to contain 4 cavities or hollow chambers. The 2 upper chambers are called atria, and the lower chambers are called ventricles. The atria are smaller than the ventricles, and then their walls are thinner and less muscular. Both atria will have an ear-like extension called the auricle. Atria are then often called receiving chambers because the blood enters the heart through the veins that open into these upper cavities. Eventually, our blood is pumped from the heart into arteries that exit from the ventricles. These ventricles are therefore sometimes referred to as the discharging chambers of the heart. The wall of each chamber, which is composed of cardiac muscle tissue, is usually referred to as myocardium. The septum between the atrial chambers is called the intraatrial septum, and the intraventricular septum is going to separate the ventricles. Each chamber of the heart is going to be lined by a thin layer of very smooth tissue, which is called the endocardium. Inflammation of this lining is also referred to as endocarditis. The heart covering, which is known as the pericardium, will consist of 2 layers of fibrous tissue with a small inner space in between them. The inner layer of the pericardium is called the visceral pericardium or the epicardium. It covers the heart and kind of like the way an apple skin covers an apple. The outer layer of the pericardium is called the parietal pericardium, and it fits around the heart like a loose fitting sac that allows enough room for the heart to beat. The heart serves as a muscular pumping device for distribution of blood to all parts of the body, and contraction of this heart is called systole, where relaxation is called diastole. When the heart beats, then the atria contract first, forcing the blood into the ventricles, and once filled, the 2 ventricles will contract and force blood out of the heart. The 2 valves that separate the atrial chambers above from the ventricles below are called the atrioventricular valves or the AV valves. The left AV valve is known as the bicuspid valve or the mitral valve, and it's located between the left atrium and ventricle. The right AV valve is also called the tricuspid valve. Sorry, the words were not making sense. It's called the tricuspid valve. It's located between the right atrium and the ventricle. And the AV valves will prevent backflow of blood into the atria when the ventricles contract. The semilunar valve or the SL valve, these are located between each of the ventricular chambers, and it's a large artery which carries blood away from the heart when your contraction occurs. The ventricles, much like the atria, will contract together. Therefore, your 2 semilunar valves will open and close at the same time, and the pulmonary semilunar valves that are located at the beginning of the pulmonary artery, and it allows the blood going to the lungs to flow out of the right ventricle during systole and then it prevents it from backflowing into the ventricle during diastole. The aortic semilunar valve is located at the beginning of the aorta, and it allows the blood flow out of the left ventricle up into the aorta, but it prevents backflow into this ventricle. If a stethoscope is placed on the anterior chest wall, you have two distinct sounds that can be heard. They are rhythmical and the repetitive sounds that are often described as a lub dub. The first, or the lub sound, that is caused by the vibration, which is an abrupt closure of the AV valve as the ventricles will contract. Closure of those AV valves prevent blood flow from rushing back up into the aorta during the contraction of the ventricles. And then this first sound is a longer duration and lower pitch than the second. The pause between this first and second is going to be shorter than that after the second sound of the lub of the next systole. When the heart beats, the first atria contract simultaneously. This is atrial systole. After the ventricles filled with blood, they contract together during ventricular systole. Although the atria contract as a unit, followed by the ventricles below, the right and the left side of the heart will act as separate pumps. Blood enters the right atrium through two large veins called the superior vena cava and the inferior vena cava. The right heart pump receives oxygen-poor blood from the veins, and after entering the right atrium, it is then pumped through the right atrioventricular valve and then enters the right ventricle. When the ventricles contract blood in the right ventricle, this pump through, or it does pump through the pulmonary semilunar valve into the pulmonary artery and eventually to the lungs, where oxygen is then added and carbon dioxide is lost. Blood rich in oxygen it will return to the left atrium of the heart through the pulmonary vein. It then passes through the left AV valve into the ventricle. When the left ventricle then contracts, then the blood is forced through the aortic semilunar valves into the aorta, and it is distributed to the body as it should. To sustain life, the heart muscle pumps blood through the body on a regular and ongoing basis. As a result, the heart muscle, or the myocardium, requires its own constant supply of blood containing nutrients and oxygens that are effective for function. The process of the delivery of oxygen and nutrient-rich atrial blood to contract muscle tissue, and then the return of oxygen-poor blood from this active tissue to the venous system, that is called coronary circulation. In both coronary thrombosis and coronary embolism, you have a blood clot that is then plugged up some part of a coronary artery. Blood cannot pass through the occluded vessel, so it cannot reach the heart muscle cells that it normally supplies. Deprived of oxygen, the cells soon become damaged or die, and in medical terms, myocardial infarction, or an MI, or sudden tissue death, occurs. An MI, also referred to as a heart attack, is a common cause of death during middle and late adulthood. The term angina pectoris is used to describe the severe chest pains that occur when the myocardium is deprived of adequate oxygen. It is often a warning that the coronary arteries are no longer able to supply enough blood and oxygen to the heart muscles. And then a coronary bypass, or coronary artery bypass graft, is common treatment for those who suffer from a severely restricted coronary artery blood flow. With this procedure, veins or arteries are going to be harvested and removed from other areas of the body, and it's going to be used as a bypass for partial blockages in the coronary arteries. The beating of the heart, that is going to be a regular and rhythmic process. So what an engineer would call a pumping cycle. Each complete heartbeat is called a cardiac cycle, and it includes the contraction and relaxation of the atria and the ventricles, and each cycle takes about 0.8 seconds to complete if the heart is beating at an average rate of about 72 beats per minute. Cardiac muscle fibers can contract rhythmically on their own. However, they must be coordinated by electrical signals or impulses if the heart is to pump efficiently. Although the rate of cardiac muscle rhythm can be sped up or slowed down by the autonomic nerve signals. And the heart has its own built-in conduction system for generating action potential spontaneously and coordinating contractions during our cardiac cycle. The most important thing to realize about this conduction system is that all of the cardiac muscle fibers and each region of the heart are electrically linked together. The intercalated discs are actually connections that electrically join the muscle fibers into a single unit that then can conduct an impulse through the entire wall of the heart chamber without stopping. Four structures that are embedded within the wall of the heart, these will specialize in generating strong action potentials and conduct them rapidly to certain regions of the heart wall. Therefore, they will make sure that the atria contract and then eventually cross contract in an efficient manner. The main structures that make up this conduction system of the heart are the sinoatrial node, or the SA node, which is sometimes called nature's pacemaker. Next, you have the atrioventricular node, or the AV node. And then you have the atrioventricular bundle, which is also known as the bundle of His. And then lastly, you have the subendocardial branches, also known as the Purkinje fibers. Impulse conduction normally starts as a spontaneous action potential within the heart's natural pacemaker. And then from there, it spreads in all directions through the atria. Although each myocardial fiber can generate its own action potentials, because they were electrically linked together, they normally match the activity of the fabrics that make up the conduction. Give me just a second. Let me go get the door shut, okay? Sorry. Oh. So when the impulses reach the AV node, it is triggered to relay its own impulse by way of the AV bundle and then subendocardial branches to the ventricular myocardium, which will then cause the ventricles to contract. Normally, therefore, a ventricular beat will follow each atrial beat. The heart's conduction system generates tiny electrical currents that spread through the surrounding tissues and eventually to the surface of the body. This fact is of great clinical significance because the electrical signals can be picked up from the body's surface and transformed into visible tracings by an instrument called an electrocardiogram. The electrocardiogram is a graphic record of the heart's electrical activity that's obtained using the electrocardiograph apparatus. This graphic chart is also known as an ECG or an EKG. So a normal ECG tracing has three very characteristic deflections or waves called the P wave, the QRS complex, and the T wave. These deflections will represent the electrical activity that regulates the contraction or relaxation of the atria and the ventricles. The term depolarization describes the electrical activity that triggers contraction of the heart muscle, and then repolarization begins just before the relaxation phase of the cardiac muscle activity. Cardiac output is the volume of blood that's pumped by one ventricle per minute. It averages about 5 liters in a normal resting adult. The cardiac output is determined by the heart rate and stroke volume. And then your heart rate refers to the number of heartbeats per minute, and the term stroke volume refers to the volume of blood that's injected from the ventricle during each beat. Arterial blood is pumped from the heart through a series of large distribution vessels known as the arteries. The largest artery within the body is known as the aorta. And your arteries subdivide in blood flow into the vessel that become progressively smaller arteries until finally your tiny arterioles that contain blood flow into microscopic exchange vessels called capillaries. In the so-called capillary beds, the exchange of nutrients and respiratory gases occurs between the blood and tissue fluid around the cell. Blood will then drain from the capillary beds and then enters the small venules, which then join with other venules and increasing in size, eventually becoming our veins. Arteries, veins, and capillaries will differ in structure. So 3 coats or layers are found in both arteries and veins, and the outermost layer is called the tunica externum. This outer layer is made up of connective tissue fibers, which will enforce the wall of the vessel so that it will not burst under pressure. The connective fibers also connect to the extracellular matrix of the surrounding tissues to help hold the vessel in place. The tunica media, or the middle layer, is made up of a smooth muscle tissue. So this muscle layer is much thicker in arteries than it is in veins. So why is this important? Because the thicker muscle layer in the artery wall is able to resist great pressures that are generated by the ventricular systole. In arteries, the tunica media plays a critical role in maintaining blood pressure and controlling our blood distribution. This is a smooth muscle, so it's controlled by the autonomic nervous system. The tunica media also sometimes includes a thin layer of elastic fibrous tissue. The inner layer of the endothelial cells, called the tunica intima, that lines arteries and veins. So the tunica intima is also sometimes called a thick layer, or it sometimes includes a thick layer of elastic fibrous tissues. Your tunica, or a tunica intima, is equipped with pockets that act as one-way valves, and these valves will prevent backflow of blood due to gravity, muscle contractions, and other forces. Therefore, blood flow in one direction, back to the heart. Arteries and arterioles distribute blood from the heart to the capillaries in all parts of the body. So in addition, by constricting or dilating, arterioles can maintain, or by constricting, or dilating, arterioles can help maintain arterial blood pressure at a normal level. As we discuss later, arterial pressure is a major force in keeping blood flow. Capillaries function as exchange vessels, therefore they will carry out a central function of the cardiovascular system. So for example, glucose and oxygen move out of the blood in capillaries into interstitial fluid and then into your cells. Carbon dioxide and other substances will move in the opposite direction. Fluid is also exchanged between capillary blood and interstitial fluid, and venules and veins connect blood or collect blood from capillaries and return it to the heart. The larger veins also serve as blood reservoirs because they can carry blood under lower pressure, and it can expand to hold a larger volume of blood or constrict to hold a much smaller amount. As noted previously, the external pressure can turn veins, which have one-way valves, and the pumps that can help the blood return to the heart. The term blood circulation is pretty self-explanatory, meaning that blood flows through the vessels that are arranged in a complete circuit or a circular pattern. A route of circulation is a particular set of circular pathways, such as from the heart to the lungs and back, or from the heart to that particular organ and back. We've already defined systemic circulation of blood flow from the left ventricle of the heart through the blood vessels to all of the parts of the body and back to the right atrium of the heart. When blood is received back in the heart, it reaches the left ventricle, and then it must flow through another circuit referred to as the pulmonary circulation. Venous blood will then move from the right atrium to the right ventricle, then to the pulmonary arteries, to the lung arterioles and capillaries. Then the exchange of gases between blood and air takes place, converting the deep crimson color typical of venous blood into the scarlet color of arterial blood. This oxygenated blood then flows through the lung ventricles into 4 pulmonary veins, and then it returns to the left atrium of the heart. From the left atrium, it enters the left ventricle, from which it will once again be pumped throughout the body and through the systemic circulation. Hepatic portal circulation, that refers to the route of blood flow to and through the liver. The term portal means doorway, and it refers to a systemic circulatory route that is a door to a second set of systemic tissues. Veins from the spleen, stomach, pancreas, gallbladder, and intestines will not pour their blood directly into the inferior vena cava as do the veins from the abdominal organs. Instead, your blood flow from these organs is going to be detoured to the liver by means of the hepatic portal vein. The blood then passes through the capillary beds of the liver before it re-enters the regular venous return pathway to the heart. The blood then leaves the liver by way of the hepatic vein, which then drains into the inferior vena cava. I'm going to pause again for just one more second. So then the blood will leave the liver by way of the hepatic veins, which will then drain into the inferior vena cava. Circulation in the body before childbirth will differ from circulation after birth because the fetus must secure oxygen and nutrients from the maternal blood system instead of its own lungs and digestive organs. So for the exchange of nutrients and oxygen to occur between fetal and maternal blood vessels must carry the fetal blood to the placenta where the exchange occurs, and then it will return to the fetal body. 3 vessels will accomplish this purpose. They are the 2 small umbilical arteries and a single, much larger umbilical vein. Another structure unique to the fetal circulation is called the ductus venosus, and it's actually a configuration of the umbilical vein, and it serves as a shunt, allowing most of the blood returning from the placenta to bypass the immature liver of the developing fetus and empty directly into the inferior vena cava. You have 2 other structures in the developing fetus allow most of the blood to bypass the developing lungs, which will then remain collapsed until birth. The foramen oval will shunt the blood from the right atrium directly into the left atrium, and then you have the ductus arteriosus, which connects the pulmonary artery to the aorta. The term hemodynamics, that refers to the set of processes that influence the flow of blood. So as we see the main force that drives the continuous flow of blood through it. Circulatory route is known as blood pressure. And so a good way to explain it is a good way to explain blood pressure might be the first answer to a few questions. First, we want to answer what is blood pressure. So just what the words indicate, blood pressure is the pressure or the push of blood as it flows through the cardiovascular system. Second, where is the blood pressure, or where does the blood pressure exist? Our blood pressure does exist in blood vessels, in all of our vessels, but it's highest in its arteries and lowest in its veins. In fact, if we listen, and according to the amount of blood and the pressure within them and draw a graph, then the graph looks like a hill with an aortic pressure at the top and then a vena cava pressure at the bottom. The blood pressure hill is spoken as of the blood pressure gradient. More precisely, the blood pressure gradient is the difference between the 2 blood pressures. So the blood pressure gradient for the entire systemic circulation is the difference between the average or the main blood pressure in the aorta and the blood pressure at the termination of the vena cava where they join the right atrium of the heart. The main blood pressure of the aorta is 100 millimeters of mercury, or mmHg. And then the pressure at the termination of the vena cava is 0. Therefore, with these typical normal figures, then the systemic blood pressure gradient is 100 millimeters of mercury. So now that we've defined blood pressure, let's talk about what makes the blood pressure change from time to time. The direct cause of blood pressure is the volume of blood in the vessels. So the larger the volume of blood that's in the arteries, the more pressure of the blood it exerts on the walls of the artery. So the arterial blood pressure will be. Conversely, the less blood there is in the arteries, the lower the blood pressure tends to be. Another factor can be the strength and the rate of heart rate. Since these can affect our cardiac output, it can also affect our blood pressure. So each time the left ventricle contracts, it squeezes a certain volume of blood into the aorta and then into the other arteries. The stronger each contraction is, the more blood it pumps into the aorta and the arteries. Conversely, the weaker the contraction is, the less blood it does pump. The rate of heartbeat may also affect the arterial blood pressure. You may understand that when the heart beats faster, the more blood enters the aorta, and therefore the arterial blood volume and blood pressure would increase. This is only true if the stroke volume does not decrease sharply when the heart rate increases. Often, however, when the heart beats very fast, each contraction of the left ventricle takes place so rapidly that it has little time to fill with blood, and therefore it squeezes out less blood than usual into the aorta. Another factor that needs to be mentioned in connection with the blood pressure is the viscosity of blood, or in plainer language, its thickness. If blood comes less viscous than normal, then our blood pressure will decrease. Another factor that has a huge impact on our blood pressure gradient and therefore on blood flow is the anti-factor that changes the resistance to blood flow. The term peripheral resistance describes any force that acts against the flow of blood and a blood vessel. So viscosity of blood, for example, affects our peripheral resistance by influencing the ease of which blood flows through the blood vessels. No one's blood pressure stays the same all the time. It will fluctuate even in a perfectly healthy individual. So for example, it goes up when a person exercises strenuously. Not only is this normal, but the increase in blood pressure serves as a good purpose. It increases circulation to bring more blood to the muscles each minute, and therefore it supplies them with more oxygen and nutrients for more energy. The venous blood pressure is very low in large veins, and it falls almost to zero by the time the blood leaves the vena cava and enters the right atrium. The venous blood pressure within the right atrium is called the central venous pressure. The central venous pressure will represent the low end of the pressure gradient needed to drive blood flow all the way back up to the heart. The central venous pressure level is important because it influences the pressure that exists in a large peripheral vein. And if the heart beats strongly, the central venous pressure is low as blood enters and leaves the heart chambers efficiently. If the heart is weakened, however, central venous pressure increases and the flow of blood into the right atrium is then slowed. As a result, a person suffering heart failure who is sitting at rest in a chair often has distended external jugular veins as blood backs up into the venous network. At least 5 mechanisms can help venous blood moving back into the cardiovascular circuit and back into the atrium. Continued beating of the heart, which pumps blood through the entire cardiovascular system, is the first. Second, you have an adequate blood pressure within the arteries to push blood to and through the veins. And then third, you have your venous valves to ensure continued blood flow in one direction, which is again to the heart. Next, a contraction of skeletal muscles, which squeezes veins, produces a kind of a pumping action. And then lastly, you're changing pressures in the chest cavity during breathing that produces kind of a pumping action in the veins within the thorax. When you feel yourself take a pulse, then that is an artery expanding and then recoiling alternately. The moving wave of expansion and recoil results in the changing arterial blood pressures that occur during the cardiac cycle. When the left ventricle ejection blood ejects blood during contraction and expansion of the arterial wall is going to result. When the aortic semilunar valve closes and an injection ceases for a moment, elastic arterial walls will recoil. So to feel a pulse, you must place your fingertips over an artery that lives near the surface of the body and over a bone or any other firm base. The pulse is going to be a valuable clinical sign. They can provide information about the right strength and this doesn't make sense. Sorry, my words here, they messed up. It says that they can provide information about the right strength and it can read mystery of the heartbeat. That doesn't make sense to me. But you can also provide information about blood pressure. Pulses easily determined with or no discomfort. So when you have non-major pulse points that are named after arteries, over which they are felt. So if you look at page 300 of your textbook, you have figure 13-24. You can see all of the different non-pressure points. So typically when you go to the doctor and they take your pulse, they will measure your pulse at the radial artery on the wrist. However, if you take a look at this chart, you can become familiar with all 9. So here we're looking at some of the pathology, so disorders of the heart specific. You have congenital heart defects, which are going to be those structural abnormalities that basically are a birth defect. They are going to be the most common types of birth defects within the heart. And then the most common one of those is the ventricular septal defect, which is just going to be a hole between the 2 ventricles. And then you have your coronary artery disease, or CAD. It's also known as CHD, or coronary heart disease, or ischemic heart disease. Basically, it is atherosclerosis of the coronary arteries. So basically the hardening and the narrowing of those arteries, and that's going to reduce the blood supply to the heart. And then you've got your atherosclerosis again, which is that hardening and narrowing of those arteries. And it's typically found within the lumen of an artery, and it is a fatty deposit. Ischemia is going to be an insufficient supply of oxygen in tissues that are due to the restricted blood flow. So here, if you have cardiac ischemia, then it just means that there's that lack of blood flow, as well as oxygen to the heart. Angina pectoris, that is going to be your severe episode of chest pain due to an inadequate flow of blood from the myocardium. Your stable angina, that will occur during exercise, and then it does resolve with rest. But then your unstable angina is whenever it occurs when you are exerting yourself or at rest. Myocardial infarction is just a heart attack. Layman's terms is heart attack. There's going to be a blockage of one or more of the coronary arteries. You will have pain or pressure in the middle of the chest. Sometimes it'll spread to the back jaw and left arm. Women are more likely to have atypical symptoms, so you won't necessarily have the pain or the pressure. You'll just have weakness and fatigue. So that's why women typically don't always get diagnosed whenever they have them until after it's already over. Your heart failure typically will come in the elderly. So congestive heart failure is just going to be where fluid backup results in edema. Left and right-sided heart failure, and then your cardiomegaly, which is just the enlargement of the heart. The term carditis is just inflammation of the heart, and then your endocarditis is the inflammation of that inner lining of the heart. Disorders that can happen within the heart valves. You have heart murmurs. So with where the heart valve does not close all the way. So it does not usually require surgery, but it just you just have to monitor it. Your mitral valve prolapse. It's going to be a protrusion of the heart valve, so it results in the inability again of that valve to close completely. Valvular stenosis is exactly what it sounds like, just narrowing or stiffening of that valve. And then your heart valve disease, typically it's a degenerative disorder that prevents the heart from opening and closing, the valves from opening and closing properly. And then your arrhythmia and cardiac loss. So bradycardia is going to be a slow heartbeat. Tachycardia is an abnormally rapid heartbeat. Ventricular tachycardia, or VTAC. If you watch any of the doctor shows or the medical shows, they always throw that out. It basically is just a very rapid heart rate that begins within the ventricle. So it may not be any other part. Asystole is just meaning that you flatlined. Cardiac arrest is where the heart abruptly stops beating. A heart block is basically just a complete or partial block of the electrical signal moving through the heart. And then your LQTS, which is your long QT syndrome. It's a fast, chaotic, and potentially dangerous arrhythmia. Your blood vessel abnormalities. So you have vasculitis, which is just inflammation of the blood vessel. Temporal arteritis, which is giant cell arteritis as well. It's just an inflammation. Hemangioma is a benign tumor. Hypoperfusion. That's a deficiency of blood passing through an organ or a body, heart. And then you've got your aneurysms, arteriosclerosis, which is the hardening or the thickening or the loss of elasticity of the walls, and then your carotid artery stenosis. Again, just the abnormal narrowing that is kind of in the carotid. Within your veins, you can have chronic venous insufficiency, where the circulation is inadequate. You can have phlebitis, which is inflammation of the veins, and then varicose veins. Typically, they're going to be on your superficial veins in your leg. Thrombus is a blood clot that's attached to the interior wall, and you can see that over there on the right-hand side, where it just kind of gets caught in a little plaquey, fatty substance. And then a thrombotic occlusion is blocking of an artery. And then again, your thromboses, they can happen in pretty much anywhere, but the most common are going to be a deep vein thrombosis, which is down in the leg, a coronary thrombosis, or even a venous thrombosis that's not within the leg. Embolisms, these are just going to be a sudden blockage of the blood of the vessels. They can be air embolism or a fat embolism. They will be named typically for its location. And then again, just that embolus is just a foreign object that's circulating that should not be. And then your PVD or PAD, it's just impaired circulation to the extremities and your vital organs. One specific type could be Raynaud syndrome. It's a peripheral arterial occlusive disease, intermittent attacks that are triggered by cold temperatures or stress. And then your cholesterol, any fatty substance that travels through the blood, it's found in all parts of the body. Hyperlipidemia just means that they are elevated. And then you've got hypertension, which is commonly known as your high blood pressure. You can have essential, secondary, malignant, or pulmonary. And then hypo is any time that it is just lower than normal arterial. Some diagnostic procedures that we have. So an angiography is just going to be an x-ray of those blood vessels, and then that is going to include an injection of contrast medium. You've got your cardiac cath. So you can put a catheter straight into the vein or an artery and then guide it into the heart. Duplex ultrasound is essentially just an ultrasound that gives you blood flow mapping throughout the vessels. And then a venography is a radiographic test, so just an x-ray test. Again, you've got your contrast side essentially there. Your ECGs or EKGs, those are just going to record the electrical activity of the heart or the heart muscle. Holter monitors, those are going to be portable ECGs. Stress tests, they can be done to assess cardiovascular health. They can be done either physical stress tests or medically done, medicinal. And you've got your thallium stress test, which is going to evaluate the blood flow through the coronary arteries during that exercise. And then here's all of our different types of medications that we can use. You've got antihypertensives, which will help control any of those elevated blood pressure readings. Antiarrhythmic, which is going to help control any irregularities. Anticoagulant, so it's going to slow the coagulant. It's essentially going to prevent any new clots from forming. You've got cholesterol lowering medications, digitalis, which is going to help strengthen the heart contractions, thrombolytics, which are going to bust up any clots or dissolve any clots that are there. TPA can also dissolve any of those damaging blood clots. Vasoconstrictor can cause your blood vessels to narrow. And then a vasodilator is going to do the opposite. It's going to cause them to expand. And then you've got your nitroglycerin, which is going to be a vasodilator. Hypertension, you've got some dietary approaches to stop the hypertension. One's known as the DAC diet. It essentially is going to be like a reduced sodium intake, things along those lines. You've got a high cholesterol diet. So you're going to limit yourself in saturated fat and cholesterol. And then you can have cardiac surgery, but it's always the last resort. But if none of these other options work, then that's always there. So an angioplasty, that's just going to mechanically widen and narrowed or obstructed blood vessel. And then a balloon angioplasty is basically just going to take a small balloon on the end of the catheter. They'll get it to where it needs to be, and then they will inflate it, and then that plaque is pressed against the artery wall. So it doesn't remove the plaque, it just kind of narrows the thickness of the plaque so that you have a bigger area for the blood to flow. You can use stents, which are wire mesh tubes that helps provide support to those arterial walls. Atherectomy, they can actually go in and remove that plaque buildup if necessary. And then a carotid endarterectomy, if you have clogged carotid arteries that are leading to the brain, they can go in and actually remove a portion of it. The most common type of open heart surgery that you'll see is what we will affectionately refer to as a cabbage, because it's a lot easier to remember that instead of coronary artery bypass graft. So essentially, they will take a vein somewhere from the leg or even like a mammary vein in the chest, and it will then be implanted into the heart to replace that blocked coronary artery. So they will essentially do what it says. They are bypassing that coronary artery by using a graft. If you have any cardiac arrest, arrhythmias, and valve, you can have a defibrillation, which is the electrical shock. So whenever on the shows, they always yell clear. That's what they're doing, is they're using that defibrillator. And automated external defibrillators, that's for use by non-professionals. So it's going to be the ones that like EMS use. And then you've got an implantable cardioverter defibrillator. It's going to be kind of like a pacemaker. It's going to be a double action. So it's going to not only shock, but it's going to help treat any that are currently there. And then you've got your cardiac ablation, so they can use radio frequency energy, so extreme heat, or cryoablation, extreme cold, to ablate any of those tissues that are needed. And then your valvuloplasty, your balloon valvuloplasty, essentially the same thing as what we talked about earlier. They're going to go in and actually perform a procedure and do a repair. They can replace those heart valves. Typically, they are going to be like a mechanical valve. And then you've got your transcatheter aortic valve replacement, also known as a TAVR. So that's always an option, that it can be delivered through a catheter. You've got CPR and then compression only CPR. And then here's some word root and your word root for your blood vessels. So any questions?